I'm Jeffrey Braithwaite. I run the Australian Institute of Health Innovation. My joke is I don't splice genes or cure cancer or scan brains or inject radioisotopes into people. I do something much more complex than that. I work on T3 at the other end of the system, on the care system that delivers care to patients. And I'm very interested in the interface between clinicians and patients and their relatives. And so all my headspace is spent not in the lab where most of you are. Most of my headspace is how do we have a better health system? And I'd like it to be a safer, better system than it is now. So that's my sort of contribution to science, medicine and healthcare. So it's a kind of weird position. If you're in a lab and you're thinking basic science or medical research or something like that, it's kind of a weird thing for this person to pop up and see you. Someone like me, who doesn't spend any time in the lab or doing science. I do a different kind of science though, and that's what I'm going to discuss with you. I run the Australian Institute of Health Innovation. So there's three groups in our enterprise. There's about 130 of us, about 100 researchers, PhD students, visiting fellows, professors, that sort of stuff. So I run a centre for Healthcare Resilience and Implementation Science, and I'll unpack those words shortly because that's the nature of the talk. Enrico Coira is a doctor who became a health informatician in the early days of when medicine was first really encountering computers and thinking, what's going to happen here in a digital world? And how's medicine going to exploit that? Joanna Westbrook is an epidemiologist, and she's interested in medication safety specifically, but more broadly in how do you create safer systems of care? Because I don't know how much you know about the health system at the end I work in, but all is not well. And sometimes it's not safe to be a patient, I mean, let alone to be a healthcare provider, being a clinician. And we're going to explore a little bit about that too. So we do systems research, not the human body or the endocrine system. We do research on that complex adaptive system that is the healthcare delivery system. So we use all these words like system sciences, translational approaches, innovative evidence-based solutions to specified healthcare delivery problems. That's our kind of mission in life. I'm going to unpack some of that with you. So when you start a talk like this, you know the gig. You're supposed to start with, I don't know, a quote from Shakespeare. So here's a quote that's impeccable in its logic and really grabs you by the throat. After decades of improving the healthcare system, patients still receive care that's highly variable, frequently inappropriate, and too often unsafe. A brilliant quote. Who said that? Me. I'm going to tell you why I've given that quote shortly, but what I want to know is, do you agree with it? Well, that troubles me if you agree with this. Normally I like people agreeing with me, but this troubles me a bit, because this is after we've spent how many decades, how many centuries trying to deliver good care to people. So there's something going on here about the health delivery system that is of great concern. We have spent lots of society's resources across all the rich and less well-endowed countries of the world trying to get healthcare right. Even saying those words, let's try and get healthcare right, seems to be almost a crazy thing to say and an impossible task. So that's where I spend my energies. So that's an interesting paradigm. I think that's an interesting paradigm for some headspace, some intellectual muscle to be spent. Here's a couple of studies that have been done though, just to show you some interesting facets of that delivery system that you're going to eventually try to affect change on. Here's a modest study we did where we looked at 105 people in an emergency department. So what we asked people, 105 people in one emergency department, a modest study, is who would you go to if you had a problem? And the lines between the circles, the individual people, are who people would say they would go to on a roster of the 105 people in the emergency department. So the first thing you can see is lots of people would go to lots of other people. So my first observation is it doesn't look like it's a toxic environment where everybody hates each other and no one would go to anybody if they had a problem. Have a look though at the colours. They are in camps, aren't they? They cluster. They cluster. So what this tells you is people cluster in their tribes. Clinicians are very tribal. And yet what we want is people to work in a multidisciplinary team, because a patient is less likely to fall through the cracks in the system if that occurs. So then we ask them, who would you go to if you had a medication problem? The social network diagram changes, but they still cluster in groups. Then we ask them the kicker question. This is a really interesting question. Who do you socialise with? It's less dense and bushy, but it's still clustered in tribal configurations, i.e., who do you go to if you've got a problem, if you've got a medication question, or if you socialise with people? Who do you go to? People like you. Now, we call this in social network land, we call this homophily. Birds of a feather flock together. Why it's important is we've said for years that a safe, effective health system comprises multidisciplinary teams of doctors, nurses and allied health professionals working together. Go figure. I think we've got a bigger problem than we think. Here's a study we did where in ACT Health, which is the Canberra Hospital and a couple of other health services, we went in for 4 years at their request to try and get more interprofessional practice, more doctors, nurses and allied health professionals working together more collaboratively, creating those multidisciplinary teams. 2007, 2008, 2009, 2010, these are the number of activities that my team that I deployed into the system, these are the kind of activities that we were involved with. They stimulated a whole lot of interprofessional activities, helping people work together more effectively. Then we measured attitudes of people towards interprofessionalness, multidisciplinary teamwork in years 2, 3 and 4, and it flatlined. So while we did a lot of things, a lot of activities, we worked with people intensively, did a lot of encounters, we didn't change their attitudes towards interprofessional teamwork one bit. In fact, the only thing that actually showed a change was this one, and that was their attitude towards doctor centrality. Rather than being a multidisciplinary team, at the end of their study, 4 years later, doctors were more central, rather than more multidisciplinary team orientated at the end of our time. Why that's important research though is, here was a really partnership effort to try and change the health system and nudge it into what we think is a good feature of the health system, which is more multidisciplinary teamwork. And it proved to be much more difficult, even with a receptive health system. So how difficult is it to affect change in the health system down the line? So those models where you see boxes on charts saying basic science at one end and health delivery system improvement at the other end, it's much more challenging than you think. So here's another one, and this is just a fun one. So you know, we sometimes do these studies, and my group has done a lot of these, where we do a five-point Likert scale sort of questionnaires. You know those ones. Here's an item, and do you strongly agree or strongly disagree? So what we did was we gave lots of these. We gave lots of these strongly agree to strongly disagree questionnaires on all sorts of different topics for many years. And what we noticed was a pattern. So when we gave these questionnaires to doctors, they either strongly agreed or strongly disagreed. They didn't seem to have any middle ground in their attitudes. By the way, later we went back to talk to some of the doctors who filled in the questionnaires, and they didn't know anything about the topic. But they still filled in the questionnaire, strongly agree or strongly disagree. They don't seem to have much doubt, our dear medical colleagues. Nurses, on the other hand, they flocked together. So if we started to see nurse responses here, then all the nurses in that hospital would sort of respond that way, or that way, or that way. In other words, nurses have kind of collectively organised somehow through, I don't know, osmosis or something, what the nursing position is on a question. And now they all vote that way, without sort of talking to each other. They kind of just know this. That's how nurses respond to this particular item on a questionnaire. Dear old allied health professionals, physios, speech pathologists, psychologists, people like that, pharmacists, they all clustered in the middle. They don't tend to rock the boat. They certainly don't all have strongly agree or strongly disagree as much as the doctors do. So what we think we've untapped accidentally, this is an accidental finding after doing surveys after surveys of all different kinds, is something fundamental about the nature of healthcare, the delivery system that you're going to eventually hope will take up your results. And that is, doctors, nurses and allied health professionals, if men are from Mars and women are from Venus, then doctors are from one solar system, nurses are from another, and allied health are from another galaxy. They get different training, they have a different paradigm on what healthcare is, they have different ways of working, and they're in different tribal groups. Now, try and do what those boxes on the chart simplistically say, which is take your results and go and put it in the delivery system and it'll all get taken up unproblematically. No, it won't. Because this is a complex adaptive system with thinking people who behave individually and collectively different from the way we actually think they behave. I don't know if you know, but healthcare is not as safe for patients as we'd like it to be. About 10% of admissions to hospital acquire some sort of iatrogenic harm, healthcare-induced harm. It might be an infection or a fall while in hospital or the wrong drug, wrong dose, whatever. An error occurs. Now, we've spent on this patient safety problem billions. Billions of euros, dollars, pounds, whatever your currency is. Billions across the world. And we haven't affected any change in that 10%. That 10% stuck. For 25 years, no one's measured anything different to 10%. When you think about it though, maybe we're looking for solutions in the wrong place. Because what that means is 9 out of 10 patients sail through this complex system, navigate through it somehow, get to the other end, and don't sustain any harm. That's the actual mystery of the health system, not that we deliver harm to 10% of patients. Of course that's a problem and we should continue to try and eradicate harm. But do we know anything about when the healthcare system produces no harm, the other 90%? And the answer is not much, we never study it. You know why? Because when patients sail through, navigates through this complex system and gets out the other end and isn't harmed, we never think about that because we think that's what the health system should do and therefore there's nothing to investigate. But actually that's gold dust. We should really investigate how can we get it right so often. Instead of trying to do what humans always do, which is let's solve the next problem. What we're trying to think is, where does the health system get it right? Where is it that despite this complex adaptive system, we get it right so often? Shouldn't we examine that? Shouldn't we understand that? And shouldn't we then do more of it?